Talk about microcytic anemia as the anemia of chronic disease and sideroblastic anemia. Very simple and very quick to go through. So, in anemia of chronic disease, it can be, the chronic diseases can be either, yeah, so it can be cancer or any kind of infection, or it could be any kind of organ failure, or it could be because like CKD can be there, CLD can be there, chronic kidney disease and chronic liver disease, any of those which will have inflammation going on. So that's important. Inflammation is going on, then we're gonna have anemia of chronic disease. So what happens? This is the whole scenario. We have chronic disease, any kind, then that is going to increase the acute phase reactants, and they're going to be produced from liver. So hepcidin is also an acute phase reactant. That is going to increase, and that is going to sequester iron at its storage sites, and that is going to decrease iron transfer from macrophages to erythropoietic precursors, because macrophages does release iron, so it's going to decrease that release of iron. And it is also going to suppress EPO or erythropoietin, that also will decrease iron, suppression of erythropoietin. This is done in order to prevent bacteria from accessing iron, because bacteria needs iron to proliferate and to propagate. So because altogether, not only for bacteria but also for the body, iron is decreased, that's why we're going to have anemia. Now what's worth noting are the labs here. Of course, we have microcytic and hypochromic RBCs. Ferritin is increasing because there is ferritin. It's not that there is no ferritin, it's just hepcidin coming, and it is decreasing the serum iron. So we have decreased serum iron, and of course we have also decreased TIBC because in the blood it's less. So ferritin is normal, it will increase, but the blood labs are going to be decreased, and of course saturation is going to decrease as well. And then there's going to be increase in free erythrocyte protoporphyrin, because we have protoporphyrin to form heme, but we don't have iron. So that's why this will increase, but there's no iron to form heme. So that's why protoporphyrin is increased. So that's it for anemia of chronic disease. Next is the sideroblastic anemia, which is due to deficient protoporphyrin. Now, how can it happen? So this is the synthesis of heme. I'm just going to go quickly through it. We have succinyl-CoA and glycine come together in the sigma ALAS enzyme that's going to form delta. So this is delta AL aminolevinolate, and then ALA, and then this is two aminolevinolates are going to come together, and they're going to form porphobilinogen by ALAD enzyme, that is aminolevinolate dehydratase. Porphobilinogen is going to form porphobilinogen. Then we have the this whole pathway that is going to give us heme. So important stuff here are only three. We have ALAs and ALAD and ferrochelatase. Lead is going to give negative feedback to ferrochelatase and aminolevinolate dehydratase, and these are going to lead poisoning can then cause decreased heme for production. That's going to give you sideroblastic anemia. And then we have ALAs, that is aminolevinolated, and that is due to decreased B6, because B6 is a cofactor for aminolevinolate synthase, and that is again going to cause decreased heme. And alcoholism, it certainly destroys mitochondria, because half of the steps of the synthesis occurs in mitochondria, and the later steps occur in the cytoplasm. And that's why when mitochondria are destroyed, of course half of the pathway cannot be completed. So alcoholism is going to also cause sideroblastic anemia. So because there is deficient protoporphyrin and iron is then trapped in the mitochondria, so these iron-laden mitochondria forms rings around erythroid precursors that forms ringed